us today about the biochemical markers in pregnancy that we see in the first and in the second trimester screen. Anna has a passion for that. She's collecting data on our IUGR patients in order to try and define IUGR at 20 weeks. According to Dr. Julian Martinez, the first author on the IUGR practice bulletin, we really do not know how to diagnose IUGR at 20 weeks. And hopefully Anna is going to help us with that. She is also looking at the biochemical markers that can be associated with that. Anna will not be talking much about unexplained MSAFP. We have done that in the past. This is a lecture on its own. She's going to touch very lightly on estriol because this can be a future fetal therapy. With that said, Anna, we look very much forward for your presentation.
So I'm going to present first and second trimester serum markers and adverse pregnancy outcomes. As she said, I'm only going to focus on PAPA, HCG, and a little bit of estriol. So the outline, I'm going to do a short review of sequential screen, description of adverse pregnancy outcomes related to all of these markers in the first trimester, PAPA and HCG, in the second trimester, HCG and estriol. I'm going to talk about maternal serum aneuploidy markers in combination, approaches to improve prediction of adverse outcomes, management strategies, and conclusion. And just of note, all of this is in the setting of patients that have no chromosomal or structural anomalies. So the sequential screen, first we do a first trimester screen that includes PAPA, HCG, and the nuchal translucency. Then in the second trimester, we do HCG, MSAFP, estriol, and inhibin A. This is from ACOG, just to review. The first trimester screen from 10 to 13 and 6, and then the quad screen from 15 to 22. And for the sequential screen, you can provide their first trimester results to patients. What about PAPA? So PAPA is a protease for insulin-like growth factor binding protein. It is synthesized by the syncytial trophoblast, and low levels of PAPA are associated with increased IGF binding protein and consequently with lower levels of free IGF. In the next slide, I'm going to show what I just said. So as I said, PAPA is a protease. You can see here that the insulin growth factor binding protein, the grade 1, is combined with the IGF. So what PAPA does is that it cleaves the insulin growth factor binding protein from the IGF, and it lets the IGF join its receptor. So that's why it is very important, because it allows the IGF to join the receptor and do all the functions. And IGFs, they are associated with control uptake of glucose and amino acids in cultured trophoblasts. And they are thought to play a significant role in the control of trophoblast invasion of the decidua. Now, low PAPA in the first trimester and adverse pregnancy outcomes. So it has been related with all of these that you can see here: preeclampsia, early pregnancy loss, stillbirth, preterm birth, FGR, small for gestational age, and placenta accreta. In the next slides, I'm just going to review the most important papers related to serum markers and adverse pregnancy outcomes. So this is the FASTER trial in 2004. It includes around 33,000 pregnancies, and PAPA less than the 5th percentile, which is 0.4 MOMs, was related with all of these outcomes that we're going to see in the next slide. So in this table, we can see that PAPA less than the 5th percentile was significantly associated. So you can see here with spontaneous pregnancy loss, less than 24 weeks, more than 24 weeks, preterm birth, less than 37, less than 32 weeks, all the pregnancy-induced hypertension, birth weight, less than the 10th percentile, less than the 5th percentile, and placental abruption. And there was also a consistent pattern of increased risk of an adverse outcome as the PAPA level became increasingly extreme, from the 10th percentile to the 1st percentile. This is an important table that shows the performance characteristics of the low PAPA. So these are the outcomes that I just mentioned, and you can see that PAPA has a low sensitivity and a low positive predictive value. This is from the VUN study group, 2004. It included almost 8,000 participants, and they also showed that there was a significant association between PAPA less than the 5th percentile and fetal loss less than 20 weeks. They also mentioned that extreme values of either HCG or PAPA, either high or low, were not associated with an increased risk of pregnancy loss more than 20 weeks in this paper. So this is to mention what I just said, that PAPA less than the 5th percentile, that is 0.4 MOMs, was associated with pregnancy loss at less than 20 weeks. This is another paper, 2008, by Nicolaitis, a multi-center study in the UK, singleton pregnancies without chromosomal abnormalities. It included 46,000 pregnancies with normal birth weight and 3,500 pregnancies that had small for gestational age babies. They did T21 or aneuploidy screening with nucleotranslucency and the serum markers between 11 and 13 and 6 weeks. PAPA less than the 5th percentile was associated with a small for gestational age. As you can see here in this table, these are the odds ratio. The odds ratio was 2.7 for SGA less than the 10th percentile with a detection rate of 12%, and SGA less than the 3rd percentile had an odds ratio of 3.6 with a detection rate of 16%. In this table, you can see that the lowest PAPA levels are associated with the highest positive likelihood ratios for the adverse outcome. So the more extreme the values, it is the worse the outcome. So you can see here, for example, PAPA less than 0.2 MOMs, as we can see here, the likelihood ratio is 7 for birth weight less than the 3rd percentile. Sorry. But if the PAPA is less than 0.4, the likelihood ratio is 4 for birth weight less than the 3rd percentile. This is another study from the VUN study group. It included 8,000 patients, multi-center study as well. They also found an association between low PAPA less than the 5th percentile, fetal loss less than 20 weeks, birth weight less than the 10th percentile, and preterm birth less than 34 weeks. This is a systematic review and meta-analysis 2017, included 32 studies, 175,000 pregnancies. Also PAPA had a moderate association with birth weight less than the 10th percentile, birth weight less than the 5th percentile, preeclampsia, preterm birth. But again, that is very important. The predictive ability was poor. Now, high PAPA and abnormal placentation in the first trimester. This is a study from 2018. It included 88 participants that had placenta previa, and they all had a first trimester screen. And they noted that patients that had previa and Angarita versus patients without Angarita had higher values of PAPA and higher values of HCG. This is another paper from 2021. It's a retrospective study, 177 participants. They had 3 groups, 35 patients with placenta previa Angarita, 30 with non-adherent previa, and 112 controls. They also find an association with high PAPA MOMs with the patients that had the previa Angarita. The odds ratio was 3.5. Now I'm going to talk about HCG in the first trimester. So HCG is synthesized by the syncytial trophoblast, and the main function is the maintenance of the corpus luteum in early pregnancy, and low levels appear to be associated with early pregnancy loss. This study, the same study by Nicolaitis that I mentioned before, 2006, included 54,000 singleton pregnancies, no chromosomal abnormalities, and an HCG less than the 5th percentile, which corresponds to 0.4 MOMs, had odds of fetal loss less than 24 weeks. The odds were increased 3-fold for pregnancy loss less than 24 weeks. This study from the BUN group that I mentioned before, 7,900 participants, also showed a significant association between HCG less than the 5th percentile and fetal loss less than 20 weeks. This table I showed before, but now we're going to focus on the HCG less than the 5th percentile. It is significantly associated with pregnancy loss less than 20 weeks. The FASTER trial did not find a significant association between HCG less than the 5th percentile and early pregnancy loss. But when the HCG was less than the 1st percentile, it was associated with increased risk. And these, in contrast, the elevated levels of HCG or PAPA, as you can see here, more than the 95th percentile, and also for HCG, were not associated with either an increase or decrease risk of pregnancy loss. Now, low HCG and fetal loss more than 20 weeks in first trimester too. So this study showed that HCG less than the 5th percentile had twofold increased odds of having fetal loss more than 24 weeks. The FASTER trial did not show a significant association between low HCG and late pregnancy loss. Now in terms of HCG and birth weight in the first trimester. The FASTER trial again. So HCG less than the 5th percentile was associated with birth weight less than the 10th percentile. The odds ratios were 1.5. The BUN study group showed that an HCG less than the 1st percentile was associated with an increased risk of birth weight less than the 10th percentile, but there was no relationship with HCG less than the 5th percentile and birth weight less than the 10th. There was no association between low HCG levels and other adverse obstetric outcomes like preterm birth and preeclampsia, or between high levels of HCG in the first trimester and adverse pregnancy outcomes. Now, high HCG in the second trimester. It has been associated with preeclampsia, early pregnancy loss, stillbirth, preterm birth, and low birth weight. This study in 2006 had 344 participants, and they didn't note an increased risk in adverse obstetric outcomes in women with HCG more than 2 MOMs. But when the HCG was more than 3 MOMs, that they did noted an increased risk of preterm birth in the setting of preeclampsia, or if it was more than 4 MOMs, they noted an increased risk of preterm birth for fetal indications like oligohydramnios or FGR or non-reassuring fetal heart racing. A study by Spencer reported that isolated HCG levels more than 2 MOMs were not associated with an increased risk of low birth weight, FGR, preterm delivery, and fetal death at or after 24 weeks of gestation. And there was no relationship between low levels of HCG in the second trimester and adverse obstetric outcomes. For HCG, a lot of data has been conflicting in terms of the association with pregnancy outcomes. Now, in terms of abnormal placentation, this is a study in 2019. It is a retrospective case control study. They measured MSAFP and HCG between 16 and 20 weeks. They had 4 groups, Angarita, Previa, a group that had both Angarita and Previa, and another one that had normal placentation. They had 301 deliveries total, and they noted that each abnormal group individually had a higher median MSAFP and HCG MOMs than controls. So patients with abnormal placentation in this group had a higher MSAFP and HCG. And the highest values were noted in the Angarita group. They also had a cutoff value of 1.2 MOMs for HCG with a sensitivity of 53% and a specificity of 68% for abnormal placentation. And as you can see in this table, MSAFP or HCG, or if both are elevated more than the 75th percentile, had an odds ratio of 2.2 for abnormal placentation. These are 2 other studies that evaluate also HCG and abnormal placentation. The first study included 28 patients with placenta previa, and they mentioned here more the cutoffs that they used. For HCG, it was more than 2.5 MOMs. The odds ratio was 3.9 for previa. And this other study that included 60 patients with placenta Angarita, they also noted that MSAFP and HCG were significantly higher as compared to controls in patients that had Angarita. And the cutoff that they used was also 2.5 MOMs for both. And the odds ratio, if the HCG was more than 2.5 for Angarita, was 8. Now, just a little bit about unconjugated estriol in the second trimester. So here you have the mother, placenta, fetus. So estriol is produced by the placenta by conversion of 16-hydroxy dehydroepiandrosterone sulfate to androgens. So you can see here, it's produced by the fetus and then is converted to androgens and then is aromatized to estriol. 90% of the estriol production is accounted for by dehydroepiandrosterone derived from fetal adrenal glands. I cannot say that word. Estriol less than 0.2 MOMs has been related to fetal diagnosis of congenital adrenal hypoplasia, estriol sulfatase deficiency, Smith-Lemli-Opitz syndrome, and estriol less than 0.5 MOMs has been related to FGR, early pregnancy loss. And elevated levels in the second trimester have not been associated with adverse pregnancy outcomes. And this is a study by Dr. Roman from 2014. They were doing the association between different degrees of placental vascular dysfunction and serum analytes. So as you can see here, these are the different groups, FGR and absent reversed and diastolic flow, or FGR with elevated Dopplers, or FGR and normal Dopplers and appropriate for gestational age. So extreme levels of each analyte were significantly more common in the FGR reversed and diastolic flow group than in the appropriate for gestational age group, as we can see here. This is just a table just to go when I send you the slides, this summarizes all the prior slides. Now maternal serum aneuploidy markers in combination. So many studies have also evaluated if combining them would improve the performance of these serum markers. As you can see here, we have here the outcomes, and here the individual markers, and here the markers in combination. So the risk of having an adverse outcome increased significantly if a patient has 2 or more abnormal markers. So as you can see here, the odds ratios start increasing when you combine the markers for all of these outcomes that you can see here. And the sensitivity and positive predictive values using combination of markers is relatively low. As we can see here, the different outcomes on this side, the sensitivity is low and the positive predictive value is low. Now, what are the approaches to improve prediction of adverse outcomes? So there is combined multi-marker screening that combines maternal characteristics and biophysical and biochemical measurements, including the mean arterial pressure, the uterine artery pulsatility index, PAP-A, or placental growth factor. Study by Dr. Roman. As I mentioned, they had different groups with different degrees of placental dysfunction. They had FGR with absent and diastolic flow, 90 cases, 46 with elevated Dopplers, and 250 cases with normal Dopplers. And the controls were 2,500. They concluded that a combination of abnormal markers detected 73% of FGR babies with absent and diastolic flow, absent reversed and diastolic flow. And when the maternal risk factors were included into that calculation, it increased to 91%. We can see that here, the detection rate of 73%. There are others that have used other risk models, combining all these different parameters that I mentioned before. This one, for example, combines high risk, like major factors and minor factors, as you can see here, and it tells you if you have high risk or low risk for an adverse outcome. This one is competing risk model for small for gestational age. This model combines PAP-A measurements and maternal characteristics. And the conclusion of this paper was that it improves the prediction of SGA more than other predictive models. or others use logistic regression, and they estimate the individual risk of each woman as a quantified risk instead of saying high risk or low risk. And it can be used the same way as a predictive model for trisomy 21. And this paper in particular was performed in a Thai population in a specific, so it cannot be generalized. This one is also a predictive model for preeclampsia, in particular, a paper from 2018 by Nicolaitis. They combined 3 multi-center studies, 61,000 singleton pregnancies, 2.9 developed preeclampsia. And the best performance was a combination of multiple factors like maternal characteristics, the blood pressure, the pulsatility index of the uterine artery Dopplers, and the placental growth factor. The detection rate for preterm preeclampsia in this study was 69%, and at term preeclampsia was 40%. And interestingly, serum PAPA did not provide any significant improvement to any combination of biomarkers, which included the placental growth factor, as we can see here. So we have here preeclampsia less than 32 weeks and the detection rate, and these are all the combinations that they did. And if they include placental growth factor, and then they add PAPA, it doesn't really change the detection rate. So what are the management strategies if we have an abnormal serum marker? So in the United States, currently, there is not a uniformly accepted practice for the care of women with abnormal maternal serum markers regarding the risk of future obstetric complications. According to the Royal College of OBGYN and New Zealand guidelines, if you have a PAPA less than 0.4 MOMs, this is considered a major risk factor for SGA, and they recommend growth ultrasounds and umbilical artery Dopplers starting at 26, 28 weeks of gestation. This interesting paper, they combine different evidence-based guidelines from different countries for the management of FGR. As you can see here, this is the country, and these are the different markers or parameters that they use. The United Kingdom and New Zealand, as I mentioned, they consider low PAPA. They have different thresholds. If they have an abnormal PAPA, they do growth ultrasounds and Dopplers. Canada, they use 2 serum markers. If they're abnormal, that would be increased risk for SGA. And the United States mentions that there's no evidence for improved outcome. So there are no guidelines that recommend the screening markers as a screening test for adverse pregnancy outcomes. Per ACOG, it says, although other approaches to FGR screening have been studied, like universal 3rd trimester ultrasound, uterine artery Doppler, PAPA, there is no evidence that these fetal growth restriction screening methods improve outcomes. For the Canada guidelines, they consider biochemical screening tests for trisomy 21 as a test for placental insufficiency. And they do recommend uterine artery Dopplers at 19 to 23 weeks if those biochemical markers are abnormal. This is also from the Society of OBGYN from Canada. They mentioned that further research is recommended to identify the best protocol when someone has abnormal serum markers. They do recommend consulting MFM to determine the surveillance plan that can range from enhanced patient education about signs and symptoms of the most common complications, increase the frequency of antenatal visits, serial growth ultrasounds, AFIs, increase fetal surveillance, do cervical length measurements, or 2nd trimester uterine artery Doppler. So what is the recurrence in future pregnancies? So there was a retrospective study with singleton pregnancies. They had 1st and 2nd trimester screen. It included 1,400 participants that had 2 consecutive pregnancies. And the conclusion was that the presence of more than 1 extreme serum analyte in a prior pregnancy significantly increased the likelihood of having 1 extreme analyte in the subsequent pregnancy. And the likelihood increased as the number of prior extreme markers increased. They also mentioned that in patients that had a normal outcome in that pregnancy and they had 2 or more extreme serum analytes in a prior pregnancy, there was an increased incidence of adverse pregnancy outcomes in the subsequent pregnancy. The relative risk was 5.4. In conclusion, maternal serum levels of the 1st and 2nd trimester screen have been shown to be associated with adverse obstetric outcomes in the absence of aneuploidy or neural tube defects. And the likelihood of an adverse obstetric outcome increases as the value of the marker becomes more extreme or as the number of the abnormal markers increases. Now, the sensitivity and positive predictive value for the individual outcomes are too low for them to be clinically useful as screening tests. An improvement of predictive values with the addition of maternal characteristics and other biomarkers has been seen. And at this time, there are no proven management strategies to manage patients with abnormal markers, and universal screening for these is not recommended. Thank you, Dr. Roman and Dr. Alcoatli, for reviewing my slides. Any questions?
You did amazing, Anna. Thanks for all of this challenging education. You know,
Thank you, Dr. Alcoatli. I know it was dense.
Yeah, so, you know, you had to go from the faster trial, you know, and then to the BUN, and then to the United Kingdom studies, and then you had to show, you know, how the numbers changes depending on the patient population, basically. And I think for almost 10 years before the meta-analysis came out earlier in the 2000s, once we started to do the first trimester screen, any patient with low PAPA-A, we used to bring them for an estimated fetal weight, basically. In the third trimester. I really stopped doing that once the meta-analysis, you know, by Halscott came out in 2014, basically. But for 10 years almost, we continued to do that, and I think it's still useful to review these values and to really look at them and to learn them also. So if I'm having someone, I'm suspicious Angarita or no Angarita, that's why in the ultrasound unit, I asked, okay, what was her MSAFP? If her MSAFP was high, you know, I'm going to be more suspicious, and the spine was fine, that probably it is an Angarita. And then, Dr. Oliver, can you tell the team here, PAPA-A, what would be a genetic abnormality we have to think about when the PAPA-A is abnormally low? The fetal therapy you did for us about that.
I'm blanking, I'm sorry.
No worries, I know, I like surprised you. So
Oh, the rats?
yeah. Yeah, so
remind me?
Yeah, so autosomal trisomies. So basically, you know, for the fellow candidates, I'm not sure, you may have heard about this term, you may not have heard about this term, but you know the common trisomies, 13, 18, and 21. However, you can have a trisomy for chromosome 2, chromosome 4, chromosome 5, chromosome 7, 6, you know, almost any chromosome you can have a trisomy. Now, it may end up with a missed abortion, it may end up with a live birth also, but PAPA-A can be affected with the autosomal trisomy, and so PAPA-A is a marker for autosomal trisomies. I think this is very powerful because you know, Anna, you convinced us that really these biochemical markers, you know, even though there are many individual studies that say, you know, probably increased risk of preeclampsia, probably increased risk of IUGR, pregnancy loss, preterm birth, really there's, you know, it's difficult for these though, you know, with the sensitivity, specificity, positive and negative predictive value to tell us what's the chance that any of these is gonna happen. So even though the echo quote unquote says that, I wouldn't ignore them completely, you know. So I would think about the total picture that the patient have in my interpretation on how I manage it. Certainly, I don't do uterine artery Dopplers that they do in the United Kingdom, you know, if I have high beta SCG. But basically keep a close eye. If the weight for that baby at her anatomy was like 18% and her MSAFP was like 3.5 and the spine looks fine, I'm gonna bring her back for an estimated fetal weight. And even if the beta SCG is very high also. So all what I'm saying is do not ignore these markers. You can use them depending on your clinical situation. With that said, it's 9:48. Are there any questions for Dr. Angarita?
For presenting on this. This is such an important topic and interesting, definitely relevant for me, for what I do from day to day. I apologize, I caught the tail end of the talk, so I would love for you to send over the slides at some point, if you wouldn't mind. But the question I had, But the question I have from what I gathered is that it sounds like that because there's still insufficient data that the management of, we wouldn't necessarily change our management of the pregnancy based off of low PAPA. So certainly something that we would want to pay attention to in regards to the pregnancy as a whole, but is this something that we feel like we should even mention to patients as part of our counseling? Or is this just something that as a provider, we should just keep in the back of our mind and use that as we're, piecing together the whole clinical picture for the pregnancy?
Let me comment on that before Anna or others chime in. I think there's lots and lots of literature, as Anna. But the bottom line is that whatever we decide, is that we have to do something similar, because this is kind of a management controversial area. Different places do different things. Like I know Dr. Dugoff is a pen and, may do something different based on what she published compared to others. ACOG obviously tells us ignore it, if there's not an increased risk of, genetic risk from these markers. And really the only thing I think, Stephanie, we do clinically, it's if the estriol is low, thinking about sulfatase deficiencies, methylamylopids, etc. But otherwise, PAPA, others, because the moment we say, or we put in a guideline, for low PAPA, we need to do a growth scan, we need to do it. And I know I haven't been involved, I haven't reviewed any cases, but I know that people can get in trouble if they say, hey, for low PAPA, I do an ultrasound, they don't do it, something happens to the baby. So whatever we decide who to, and et cetera, I think we need to be consistent.
I absolutely agree with you, Dr. Bergalla. I think so far, what I have seen here is for low PAPA, we haven't been bringing patients back. Certainly for beta SCG as well, whether it's low or high. I think the one, I'm very traditional, correct? So we used to, but we do believe that MSAFP is associated with uteroplacental insufficiency. And I think many of us, when you have very high MSAFP with an absent new tube defect, we have bringing them back for a third trimester fetal ultrasound. But basically, I think there's really no guideline regarding this, regarding the MSAFP, basically. Yeah.
But I think to answer Stephanie's question, oh, sorry.
Yeah, but I think we've been homogeneous with what we do, Dr. Bergalla.
I think to answer Stephanie's question, though, with regard to the low PAPA, I wouldn't tell a patient necessarily about it if we're not going to bring them back for anything, because I feel like that could provide unnecessary anxiety for patients. Oh, there's one of these markers is a little bit low. This can be associated with this, and this, and we're not going to do anything extra. So I think it's something to keep in the back of our minds. This is my opinion. I'd love to hear if anyone else disagrees, but I think it's something that could just make a patient really anxious if we're not planning to act on it.
No, I agree with you, Becca, really. I think all of us in this division, we have very low threshold to bring patients for estimated fetal weight anyway. So I think I'm happy with what we do here. I don't mention it to patients. As Vincenzo have mentioned, low estriol certainly have a huge differential. So that one is different.
Yeah, I agree. Also, I counsel everybody on preeclampsia, for example, the fact that they're pregnant, they have a risk of preeclampsia. So I counsel everybody on the risk of preeclampsia. So I don't want to add on a marker and that is not highly associated. I just go by maternal medical histories and risks.
What I'm typing, and I guess I'll say it since people are, is that maybe Anna, who's reviewed it so well with Stephanie and Huda, you could put, 2 bullets in a guideline saying that, again, we do not, in general, act on these except, whatever we have talked about, estriol maybe, or whatever we decide. and that, so just to have it, you know, to objectify your practice, so to speak.
No, that's a great idea.
And Anna, don't forget this because it's in a lot of practice questions reports about all the enzymes and how DHEA goes to estrogen. So we'll be back.
Thank you, everyone.
Thank you, Anna. So Huda, do we, so in a few minutes we'll break for fellow interview.